E. fecalis, Candida, fungal species, they are no swimmers. They are attached to the catheter or attached to the walls.
Yeah.
So we're not even analyzing them as they should.
The work you've been doing with the fibrinogen has led you to developing a vaccine and antibody therapy. So can you tell us
Yes.
more about how that works and what pathogens they're effective against?
Yeah. So one of the vaccines that was really early on when we're trying to understand what are these pathogens do not cause an infection. But as soon as you put a catheter, now they are able to cause infection. So we found that, for example, E. fecalis, Enterococcus fecalis, they have this adhesion that was binding to fibrinogen. And that was the key idea, right? Like, is this fibrinogen that important? Do you block that? Can now we reduce the infection? And we found that yes. It was really amazing. It was the first time that we have an idea how the system was working, right? What was the main mechanisms for the pathogen to interact? So we developed a vaccine against enterococci, basically all that group. That this is a really big group causing those infections. And one of the things that also we developed with this vaccine is monoclonal antibodies. Like, what will happen? To have a vaccine means that you're already thinking that you're going to have an infection in the future, right? Like, you're going to have a urinary catheter. We need is something to protect, right? So you need to have the vaccine before even you have the catheter.
Okay.
But what would happen if you're already in the hospital, you have an infection with a multi-drug resistant enterococci, vancomycin resistant enterococci? They actually is a major problem in Europe. Can we use a dose? And even if you have a pre-existing infection, can we give you a dose of these antibodies and reduce infection? And we found that yes, we were able to reduce that against our multiple enterococci strains, really virulent strains that have been isolated from patients that have died from that infection and things like that. So we developed these too. However, this is the problem. Even with COVID, people didn't want to have a vaccine.
Yeah.
For something that was killing many of us. So also, you don't want to have a vaccine if you don't even know if enterococcus is going to cause the infection. Monoclonal antibody therapy is really costly.
Right.
Because that means that you need to produce that all the time because it has a shelf life, right? So, for example, antibody therapy for inflammation, like IL-6 blockers, TNF-alpha blockers, is extremely expensive. It could be $20,000 US. So it's not feasible. So we were rethinking the situation. If this interaction, if blocking this interaction, first of all, that was with enterococcus when we started dissecting the system. But then we found that even E. coli, Candida albicans, Pseudomonas aeruginosa, Cinetobacter baumannii, and many of the different pathogens that cause infection, they were using fibrinogen for that, to form biofilms. So we say, okay, what about if this is 40% of the 40% of the infections in the hospital in the United States and Europe, can you imagine the incidence of these infections in places where we don't have the sanitation protocols, either because there is not really good medical system, or there's no even resources.
Yeah.
And I have people that have come and say, yeah, my dad died of those infections. They put complications, right? Yeah, it was a complication, but at the end it was that infection. They come from the bladder, go to the bloodstream. So we were thinking, how can we develop something that will be feasible to use? The king doesn't have a shelf life, and anybody can have access to it. And you will use it only when you need it, right? And it's when we develop modification of urinary catheters by actually understanding the system. So we develop a catheter that prevents protein deposition, not only fibrinogen, because then we were so scared, like, what about you remove fibrinogen and then any other protein will attach?
Yeah.
The same function, and then we go back to zero. So with Dr. Caitlin Howell in the University of Maine, we got together and we developed this catheter with basically prevent, it's a slippery catheter. It prevents protein to attach and also prevents the pathogen attachment, both of them. And this is perfect because you're reducing the main problem. However, the other issue that we have is inflammation, right? None of these catheters that have any coatings, antimicrobial coatings, will reduce inflammation.
Yeah.
So something that we saw, and let me explain why these were so successful and none of the other coatings were not. So some of the catheters that you have, they have the antimicrobial attached or they have a release system. But if you have all these proteins that attach on top of the catheter, that will hinder the release of the antimicrobial or will hinder the interaction of the antimicrobial with the bacteria because you have this layer in between. So that may explain the conflicting data that we have in hospitals, in clinical studies, right?
Right.
So by having these catheters, we're not using any antimicrobial. We're not using anything that's killing the pathogen. So basically we're making blind. Like if they don't know what they are, they flush away with the urine. We're happy. Everybody's happy. We don't want to develop more multi-drug resistant pathogens, right? So that was the idea that we thought it would be functional in our studies.
So where are you at with this surface technology now?
So we're working really hard to get it out, to start with clinical trials to see if it's true. Because again, one of the things that we have found is that the mouse model really mimics what happened in the urinary, like in the human infection. But we need to prove it. So right now we're in the phase that we're trying to actually test it.
Do you think those trials might be in the near future?
I hope so. I really hope so.
You should
Everything
let
is
us
about
know if
funding.
it happens.
Everything is about funding, remember?
Yeah,
So that's the
is.
thing. That's the key point. So we're really excited. And something that I didn't mention before, we were talking about this inflammation. These catheters reduce the damage because they are so slippery. So it's like they are not actually causing friction in the bladder. And we have shown that they reduce tons of inflammation markers in the bladder and actually could be a solution, right? Remember, the main problem is that we have something that causes damage. Catheters do not cause the damage and prevents protein, even if we have a little bit of damage, because if something is inside of you, the bladder will react. But even if we have a little bit of damage and we have these proteins coming through, they're not going to stick.
Yeah.
And then pathogen won't stick either because it's so slippery.
It sounds really promising, and I think there will be people in our community who are interested in participating in that trial when it happens. So if you want to share the information when it does happen.
Yes, definitely. Yes.
It's really great to hear that this type of thing is being worked on. We also got a bunch of questions about what people can do in the meantime. So we often get questions about whether medications for recurrent and chronic UTI will work for people with catheters. And that's something that we just don't see enough research on. But we did get some specific questions about things like long-term low-dose antibiotic prophylaxis and whether that's a good idea given the antimicrobial resistance problem.
So the problem that we have in the bladder is that sometimes it works, but one of the problems that we see that even with Candida auris, something that I forgot to mention before, these catheters are really good even against Candida auris that is super sticky. Like I was like, please, like it worked. So that was great because again, it's a nightmare. But one of the problems that we have and again, I have to validate with clinic data, but most of the time we don't reach a concentration that we really want in the bladder because we're constantly flushing. It's not like other organs that the antibiotic will stay there. Here is a system that is highly dynamic and is constantly flushing. It has been tons of data, clinical data, that has shown that low dose of antimicrobials prophylactic therapy have worked for some patients.
Right.
But again, we don't understand all the patient population. So I cannot speak about it because we have not tested. on that. And the problem that we have with the majority of the pathogens that cause an infection in the bladder is that they are highly resistant to antimicrobials. So we're thinking that we may allow them to evolve. Remember, for E. coli to infect, they have to go inside of the cell and seed and create these communities inside of the cell, so they are protected from the immune response and from the antimicrobials. And then they get released and they look like worms, and they go and they attach to the next one, the next cell. In this case, when we look at the biofilms that they form, they have tons of proteins, including fibrinogen. We don't know how those proteins protect them against antimicrobials and even against the immune response. Like something that I didn't mention is that we see tons of immune cells in the catheterized bladder, but it seems that they don't do anything. The question is, we don't know whether they don't see the pathogen or they conflicted signaling inflammation is hindering their antimicrobial activity. So I do not know whether that may work. And I don't know if that has been tested. In my knowledge, I don't think it has been tested in patients with a urinary catheter.
Okay. Is it the same case that we just don't know enough about non-antibiotic approaches like D-mannose and Hiprex and probiotics?
So there was an experiment done where they used an analog of D-mannose that is called Mannocide that my previous mentor developed. And they were able to see reduction of infection with E. coli. But it's because E. coli binds to sugars. So that's why when you have these mannose, it's a sugar, they bind, and it's like at the decoy molecule, they flush away. So this is the situation. D-mannose may work with those pathogens that bind to sugar protein interaction. However, so we have found that Pseudomonas, E. coli, Klebsiella, and Acinetobacter baumannii binds to sugars in fibrinogen. Fibrinogen has tons of sugars.
Okay.
It's highly glycosylated. It has mannose, it has everything that you want is right there. So they bind through that interaction. However, gram-positive bacteria like Enterococcus, Staphylococcus aureus, they bind protein-protein interaction. So that won't work. And Candida albicans, we found that they use a protein that's called ALS1. It's like a little hand, it's an adhesive they allow them to attach. So suggesting that gram-positives and fungal pathogens, they won't respond to D-mannose because they bind through different mechanisms, protein-protein interaction, not sugar-protein interaction. So D-mannose may work for those patients that have an E. coli infection, but remember, most of these infections are polymicrobial. You may remove one of them, but some of the other may take advantage of that.
Okay. A lot of these, like probiotics and Saccharomyces boulardii, are gut health supplements, so people are familiar with them for that. And that question comes up a lot about the interactions between the gut microbiome and the urinary microbiome. Have you seen these types or documented these interactions in your work?
No. So again, like everything is really new. This is most of the people that works with these infections, they focus on the pathogen. But what I believe is that we need to focus in the whole thing, right? The response of the host, the pathogen, and in the immune response. Because for some reason, the immune response is not working. So I don't know if adding a probiotic in the bladder, I don't know if the changes in the bladder and the inflammation may allow these microbes to take advantage and also increase in numbers. Right? Because again, E. coli, E. fecalis, Candida albicans, they are perfectly fine in our gut, but as soon as you remove it in this really rich environment with tons of proteins and places where they can attach, they can cause a trouble. So I don't know. I need to test that. I need to put these microbes in the bladder with a catheter and see whether we need to test that. We don't have information about it. We have tons of information about uncomplicated UTIs, but not about CO UTIs.
It is an interesting point. It's not as simple as looking at uncomplicated and catheter-associated UTIs in the same way. And that validates the questions that patients send us about catheter-associated UTI and whether they can use the same supplements. On the surface, it seems like you should be able to, but it's really not that simple?
It really depends. I always say depends, right? Like again, D manus may work.
Yeah.
Well, also D manus is in the. There is a lot of contradictory data that say that they work and sometimes they don't work. And I guess it's just the concentration in the blood. Again, if you're increasing volume, you're reducing the concentration.
Yeah.
And then if you boil, you remove the D manus completely, right? So I think that the monocytes, this molecule that I just mentioned, they have been really good, at least in the mouse model. I think it's in clinical trials right now. Not sure. But it really, the D manus have this interaction that it can bind and release from the pathogen, but these monocytes attach and they don't release anymore.
Yeah.
So even one molecule will target one
Right.
pathogen. So, and it seems that I'm not sure, I don't remember correctly, but I think that they were really good in staying in the bladder for a long time. But I need to go back and check. Yeah.
Yeah, I want to go back to the inflammation piece of this. You mentioned in your work, and I mentioned in the introduction, that this long-term catheter use and inflammation that's associated with that can be a risk factor for bladder cancer. Can you explain that connection and what your research has found in that respect?
Yeah, so one of the main things, and again, nobody, I think it's only us that we're studying this point, but if you ask many people, they have they have family or they have the urinary catheter for a long time. There are people that have paraplegia, they are paraplegic, they need that, right? So they have there is a huge link, or this is an increased data that shows a link of prolonged catheterization with bladder cancer development. So when we were looking at inflammation, right, we were saying, okay, what are the factors that are being induced? And we found that we look at bladder cancer markers, we look at inflammation markers, immune response, everything. And we see that many cancer markers, they have poor prognosis in other cancer systems, in other parts of the body, they would be inactivated in the blood when the catheter is. By 7 days, we can see a huge increase of these bladder cancer markers, and that keeps going up to 28 days. The question is that we don't know, as soon as you remove the catheter, does that go back to normal and then nothing happens again? And you just need to have this constant inflammation to actually develop these abnormalities and these carcinomas, right? Which is normally, we have seen that like gut inflammation may result in a colon cancer, right? So we have many examples where the inflammation plays a role. You don't have to have genetic factors that predispose you to develop cancer. We can see the development of cancer due to inflammation. Right. So we saw that even at 28 days that these blood cancer markers were highly elevated, right? But now we need to test, if we remove the catheter, do they go back to normal? Or this proliferative behavior stays there? So when is the point of no return? Is 7 days good? 24 weeks is good, and then you remove the catheter and you go back to normal? Do you need to have it for 3 months?
Right.
So then, remember, cancer is a silent disease. You don't notice until something is really bad.
Yeah.
So right now we're doing research on that. We're identifying the markers that are more exacerbated when you put a catheter. But the cool thing that we have found is that now we're testing the liquid-infused catheters that reduce the inflammation, and the majority of those bladder cancer markers totally are reduced.
Wow, that's an amazing outcome, because like removing the catheter is not an option for a lot of people, so you can't.
Exactly. So now, if we can have something that is really gentle, to not cause damage, but provides all the benefits, that could be something, a solution for many people. And actually, we also saw, we tested with monomicrobial infections, polymicrobial infections, and we found the E. coli exacerbate the increase of bladder cancer markers.
Right.
E. fecalis, they didn't do much, Candida a little bit, but E. coli wasn't the one they induce the most.
Okay.
But with the liquid infused, we were able to tune all of them down, even with E. coli.
So you said that bladder cancer or cancer in general is a silent disease, but what are the symptoms when it gets to that point, and how could you differentiate them from UTI symptoms?
There is no studies. We don't have anything. And I remember that I received a call, and it was really sad. We got a funding like 3 years ago. Can I say the funding agency?
If you're allowed to, it's fine for us.
Yeah, open philanthropy. They really believe in what we were doing. And the idea was to understand, how these, like, first of all, do we have bladder cancer markers? Which ones are they? And how can we dissect the whole mechanism? So that was in the news. It came out in different platforms that we got the funding. And then somebody called me and I said, "You're 30 years late." I'm like, "Sorry, I was 10 years old at that point." And I said, my brother was in the army. He had an accident. He became paraplegic. He have a catheter. He has tons of infections. He almost died in some of them. Now he developed bladder cancer. Now they need to remove the bladder and they basically put him in dialysis. And the outcome, like people with dialysis has really poor outcomes.
Yeah.
Because not infections go directly to the kidneys. So we want to understand that, right? We want to understand for these people, they are silent, right? We don't know. You get this and people telling you the stories, but we don't have studies. We don't have anything. How can you differentiate that? If your bladder is not working, how you feel pain? How do you feel that something is wrong, right?
Yeah.
So I think that we have a lot of work to do.
It sounds like it.
And I feel like sometimes limited because I receive this call from this patient, like, believe me, we're doing everything we can, but we need to pay attention.
I agree. And with the data that we do have, do we know what the instances of catheterization leading to bladder cancer?
It really, again, it's poorly studied. We have many people that have focused like spinal bifida, right? That they need a urinary catheter and they see the outcomes. But this really is like a silos in a specific population.
Right.
But we don't have anything that basically does the analysis. We don't have a widespread analysis. So one of the things that we want to do is that if we're able to work with like at the Veterans Affairs or any other agency that has tons of data over time, is to understand, like it has been really well documented with AI, if a patient, like for example, like somebody in the army, they develop this, they have all these infections, then they have the bladder cancer. Do they have comorbidities? We still don't know whether comorbidities plays a role in this situation. Can we start actually analyzing like tons of data that can indicate what could be the relationship between the different things, right? The type of pathogen, as I mentioned, right? E. coli seems to be promoting more cancer markers than others. Do we see the person that has more E. coli develop this type of infections? This type of outcome. So we don't know. And the problem also that we have is with diagnosis. Previously, we have just urinalysis, that they just take urine culture, they look for the one that's more abundant, everything else is contamination. But now we see that that's not the case.
Yeah.
And one of the things that we have, one of the major problems that we have is that with urine, we're just counting those microbes that like to swim, like E. coli, Pseudomonas, things like that. But E. fecalis, Candida, fungal species, they are not swimmers. Staphylococcus aureus, they are not swimmers. They are attached to the catheter or attached to the walls.
Yeah.
So we're not even analyzing them as they should. Like we really don't know. We're just fragmenting, just picking up whatever is in the urine.
This is a big problem in chronic UTI as well, and patients are very well aware of it. But the work that you're doing in this space is giving me hope for the future. What do you think is the most hopeful? What gives you hope in terms of solving this problem of catheter-associated infection?
So what I really think is the inflammation is the one that is affecting the whole system. If we're able to target inflammation, we will be able to develop better systems. Like, I don't know, what about if we found that, just saying, I'm not saying people have to use it. Let's say that we develop these catheters and they are in the commercially available. What about if we combine them with ibuprofen? And that totally really like reduce the tons of inflammation. So if we don't have inflammation, we don't have protein being coming from the bloodstream to the bladder. We don't have enough nutrients from the pathogens to attach. And then we have a win-win situation, right? I think that by understanding and actually doing really critical research, like we need to do a really well-documented research to say, yes, this is working. We should move there. And again, targeting inflammation, that could be the key, which the majority of the people, what does is targeting the pathogen. And I think that we have targeted the pathogen so much that we have developed all these multi-drug resistance. And also it's not healthy for the patient because they're taking all these antimicrobials. Like if my hypothesis is correct, they are taking all these antimicrobials. They are increasing the amount of E. coli, Candida, or E. fecalis in the gut, the bad microbes. And then they are able to translocate to the bloodstream. We're seeding them, right? So we're affecting our whole system. And we know now that our microflora is critical for mental health, for our metabolism, everything.
Yeah, well, it seems like the solutions might be more simple than we thought they were originally. And it would be great if that's the direction it goes in. It will be much easier for patients to recover.
I know, and just to point out something else, we don't know how these antimicrobials are affecting the bladder urobiome. We don't have any
unknowns.
Yes.
So you have to keep doing the work you're doing.
Yes. No, we're really excited. I really, like, I hear all these people that calls me, right? And there is we're trying to do our best. I'm really passionate about what we do. And I think that we can have better treatments if we understand the system better.
I agree. And I'll let you get back to all that really important work. But I want to thank you so much again for joining us and sharing your research. And I'd love to talk to you again in the future about developments in that space.
Oh, that is my pleasure. Thank you so much for inviting me and giving me this opportunity to share what we have done and to hear also the patient population.
Thanks so much for watching. I hope you found this expert video helpful. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveUTIfree.com for related articles. We'll drop some links in the video description. If you like what we're doing on this channel, you can support our work by hitting subscribe here on YouTube, and don't forget to tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.